Good morning, good afternoon, and good evening, everyone joining us today. Thank you for your time and interest in this important topic for business and for individuals facing the unprecedented challenges of life and work in the era of COVID. My name is Schweinitz, and I lead Fleishman-Hillard's global healthcare practice, a group of more than 300 communications professionals working with clients across the health sector. I work as part of a broader Fleishman-Hillard team across sectors, and we're always looking to constantly expand our understanding, offer proactive ideas and information connections to our clients. And that's why I'm absolutely delighted to introduce our guest for today's discussion, which will be facilitated by our very own Mark Senak, a senior counselor in our practice with deep expertise in the healthcare regulatory environment. He's also an author, blogger, and all-around amazing guy. So he's going to lead the charge today. Joining us from the legal consulting firm Morgan Lewis is Chai Feldblum. Chai is a partner and director of workplace culture consulting at the law firm of Morgan Lewis, where she helps companies and organizations create safe, respectful, diverse, and inclusive workplaces. She served as a commissioner of the Equal Employment Opportunity Commission, the EEOC, from 2010 to 19. And her policy background gives her great insight into helping employers on compliance with employment anti-discrimination laws, and into her investigations of complaints about harassment and discrimination. We are equally honored to be joined by Dr. Kristian Andersen, who's Director of Infectious Disease Genomics at Scripps Research Translational Institute and a professor at Scripps Research. Dr. Andersen's lab works to understand questions like how do viruses such as Zika, West Nile, Ebola, and SARS-CoV-2 emerge, spread, and evolve and go from causing small-scale epidemics to small-scale outbreaks to large-scale epidemics. And his lab is focused on using sequencing, experimentation, computational biology, and working with international collaborators on these investigations into deadly pathogens. In March 2020, his paper on the origin of coronavirus was published in Nature Medicine and helped slap down some of the rumors about this virus coming out of a lab and not out of natural evolution. As time allows, we will be taking questions. There is a question function on your dashboard. Please submit questions of any type related to this content. Also note we will be recording this session for later playback that you can pass on to colleagues who aren't able to join us live. So without further delay, I'll pass the baton to Mark to begin the discussion. Mark?
Thank you, Anne. And welcome everybody. While a great deal of the focus of discussion around COVID has been on the medical and even financial impacts of the pandemic, it's important to note that there are also legal and ethical aspects as well. It's often the case in an environment where that's more defined by what we don't know than what we do, that decisions are often made based on assumptions rather than on facts. This seems particularly true right now with policies and procedures being drafted, being put into place, and being developed as we sit really in crosswinds, where on the one hand, we have businesses and services opening up again, and on the other hand, we have a surging caseload. So today's discussion is aimed at really trying to help provide a factual framework to inform the development of policies, of points of view, of communications in this environment that is characterized by being extremely fast changing. So thank you again to both of you for joining us. I'd like to begin with Dr. Andersen really to just paint the landscape for us, clarifying where we are in the United States in terms of the profile of this pandemic. Are we in the first wave? Are we in a second wave? States are reopening. Try to paint, if you can, briefly for us so we have a good idea of the landscape, where exactly we are right now.
Yeah, so thank you, Mark, and thank you, Anne, for having me on. So to answer your first question, are we in the first wave? I would say yes. The problem is that this is not a wave. It's more like a wildfire with sort of sparks and new wildfires, flaring up all across the country. And it's really important because the reason why we're talking about waves is because we're thinking about flu, which does have waves because of seasonality. But what we can see with SARS-CoV-2 is that seasonality is not as pronounced. It doesn't mean it's not there, but it's not as pronounced. And of course, it's been fully unable to stop the transmission in this country over the summer, which I should say that most public health officials didn't expect it would either. The situation right now in the United States, I would say on the northeast coast, things are pretty good. They got really hard in the beginning, got it under control, and seem for now at least to have, transmissions down to a level where you can do some sort of normalcy. The rest of the country is in very bad shape, and some situations we'll see playing out in the south and the west, I think within the next couple of weeks is going to be catastrophic. And when I mean catastrophic, I mean much, much worse than what we have observed previously in, for example, New York City. So that's important to keep in mind when we're talking about Texas, Arizona, Florida, probably California, other places too, where we're starting to see exponential growth. But this exponential growth is now starting from already thousands of cases being reported daily, as opposed to the hundreds of cases being reported when we saw the start of the exponential growth in, for example, New York City. So for that reason, I think the situation is extremely dire in the United States at the moment. And I think within the next couple of weeks, we're going to see catastrophic situations in many of the places, showing a lot of cases being reported right now.
Thank you. Ms. Feldblum, I'd like to do a similar thing with you now that Dr. Andersen has cheered us up with that. But I would like, if you could also paint a landscape for us of the legal landscape, a picture for us of the legal landscape, particularly as it relates to institutions and workplaces preparing to affect policies in terms of risk mitigation. What legal agencies, what legal principles come into play? OSHA, EEOC, human rights commissions, state laws, what should people be putting on their radar screen? Oh, we can't hear you.
So I was just saying thank you. Thank you for having me. And the answer is all of the above. Right? So, and these laws will be in effect both in terms of issues when you're returning folks to work, and also some of them when, if, as we've just heard, there are issues, maybe people will be furloughed again. So one set of laws has to do with anti-discrimination. So Americans with Disabilities Act in terms of people with disabilities, Age Discrimination and Employment Act in terms of people who are older, and those are enforced by the Equal Employment Opportunity Commission, as well as pretty much in every state and in some localities, state or local human rights commissions. Then you have laws that deal with safety. The most important agency there is OSHA, Occupational Safety and Health Administration. That agency enforces the law that requires employers to provide safe and healthy workplaces. In that law, there is what is called a general duty clause, that is a general duty to provide a healthy workplace. OSHA has also, over the years, issued specific standards to address specific industries or specific health risks. If an employer violates one of those standards, then it automatically violates OSHA. OSHA has not chosen at this point to issue specific standards with regard to COVID-19, but it has issued guidance saying, here are the things we expect employers to do in order to meet their general duty clause. And OSHA looks to CDC, the Center for Disease Control and Prevention, for those recommendations. So it's very important to be keeping up to date on both what CDC is saying and what OSHA is saying. And then finally, in terms of laws for people who are not coming back, there is a new federal paid leave law that affects employers with 500 or fewer employees. There are state laws that of leave that are covering all employers regardless of employer size. There is, because of the CARES Act, new unemployment compensation programs that last for 39 weeks. And finally, sort of connected to the anti-discrimination, under the ADA, there are some privacy issues, protections, and almost every state has some privacy laws. So there is a whole set of laws, and that's a lot to keep on top of. Morgan Lewis has been very busy advising clients on this. And of course, there's also the stay-at-home orders and needing to comply with those.
So that was a lot of ground. Let me ask a follow-up, because you've categorized the laws very nicely: discrimination, safety, employment-related. A little bit on the privacy side, because that's going to affect not only employers, but individuals really knowing what their privacy rights are. What are we talking about? HIPAA? Anything beyond HIPAA?
Right. Well, HIPAA has a privacy component that applies to healthcare providers. So it's not going to apply to employers directly, but it applies to healthcare providers and insurance agencies, right? Health insurance agencies. To the extent that, for example, a employer wants to do testing on site, not using a lab, they'll have some of those obligations. Sometimes in terms of being self-insured, there will be some obligations, but HIPAA goes to a particular set of entities. The ADA, that will be if you're collecting health information from your employees. That's any employer with 15 or more employees. And that's really about keeping that information confidential, only those who need to know. So can't be an employee's personnel records. It has to be in a separate set of records that has that information, and that can be shared only on a need to know. There's also some privacy issues that come up when you know that someone has been infected with COVID-19. You now have a responsibility to let other employees know, to let them know you have been in close contact with someone who has COVID-19. Often those folks want to know who is it, and under ADA, EOC's recommendation is that you do not disclose the name. You simply disclose the fact you may have been infected, would like you to quarantine at home for 2 weeks.
Thanks. I'm going to go back to Dr. Andersen for a moment, because Ms. Feldblum just outlined a lot of modalities. And as we begin to adjust to life during this pandemic, service providers, businesses have to grapple with providing a reduced risk environment. Screening temperatures, regular testing of individuals, maybe even engaging in contact tracing, and having employees wear masks. I'm wondering if you can talk about how effective these modalities are and how practical their use is in a workplace or a service environment. And if we can, I'd like to pull antibody testing out and address that in a moment.
Sure. Yeah. So I think the key question, to ask yourself here is, why are you testing in the first place, for example? Because the way that we think about testing in this country is that you have some sort of disease, you go to the doctor's office and you get a test done there because you think you might be a patient. That's how we are used to testing in America. This is how we're used to testing in most places. But when we're talking about the workplace, we're talking about airplanes, we're talking about the restaurants, the reason for testing is very different. And that's really important, right? Because now we're not doing that to try and identify patients. We're actually trying to do that to take people out of the cycle that might be infecting people, for example, other people at, for example, the workplace, at the restaurant, on the plane, or wherever that is. And that's really important because that means that any one person you can take out of that chain who might otherwise go in on a workplace and transmit is a win. That doesn't mean that you need to take everybody. If you say you have 10, people that get on the workplace that might transmit the virus, if you can take out just one of those, that's a win. If you can take 5 of those out, it's a bigger win. If you can take all 10 out, that's a huge win. Now, there's no single thing that would allow you to do all of those and hit, 10 out of 10 every time. Things like temperature screening, most people don't present with a temperature when they start transmitting the virus, right, importantly. However, people that have a temperature will transmit the virus if they have COVID. So things like temperature screening might enable you to take some people out that would otherwise get onto the workplace and actually transmit the virus. So for that reason, I believe that temperature screening is helpful, not in terms of diagnosing people, but in terms of screening at, for example, the workplace. Things like wearing face mask is absolutely critical. There's no question that there's no question that wearing face mask is going to massively decrease the likelihood of transmissions on the workplace, for example. And the reason for that is that in the beginning, we thought that as long as you wash your hands and you don't contact, you don't touch things that might have COVID, you're probably going to be okay. But what we have learned now is that the primary routes of transmissions are probably not via contact. They're probably much more likely to be via droplets, maybe even aerosolized transmission in places with a lot of recirculated air. So like office buildings and things like that could be a high risk. Wearing a face mask will help decrease the likelihood of the virus sort of transmitting in that environment. And then finally, of course, the testing, which, if we could all do that at the workplace, would be great, because it's probably the one that would make the biggest difference, right? Again, the testing here is not for the purpose of diagnosing patients. It's for the purpose of identifying people that might get on the workplace and actually transmit the virus. This means that these tests don't need to be perfect. We all want perfect tests, but we probably can't have it. And that's okay, because again, things like combining testing with wearing face mask, with washing your hands, and with temperature screening, and probably also doing a health certification every morning before you get on the workplace, are all going to work together to overall make the workplace healthier.
And is there a role in the private sector for contact tracing?
So that's a question that we have been dealing with too, and I think in a perfect world, no, you would want the public health authorities to do that because they're trained to do it, they know how to do it. The problem is that we're living far from a perfect world, especially right now, and I think with that in mind, I do think that, companies and other places should have plans in place that essentially addresses the question, if we detect somebody that we think is positive or that we have confirmed to be positive, what do we do next, right? It is important to figure out from that person, who have you been in contact with, right? Who might otherwise have gotten in contact with you when you have been infected. So you can actually take those out, quarantine them, and make sure that they don't get on the workplace, or alternatively having repeat testing on these individuals if you have that in place. So yes, I do think there's some benefit to that, but again, it is tricky, right? How do you do the contact tracing? How do you ask them who have you been in contact with and things like that? These are not necessarily easy questions to actually do. And I should say, everything you do here, patient or individual confidentiality here is really important, right? Because if you have the first person who gets on the workplace who's infected with COVID and infects 100 others, it's not that person's fault, right? It's the virus's fault that happened to be in that person, and that person probably didn't know they were infected by the time they started the transmission chain, right? So for all these things, we have to think about the confidentiality. We have to think carefully about how do we actually handle that kind of information.
Thank you. So Ms. Feldblum, we talked about a lot of things there that can be done in the workplace, but you know, a lot of these risk moderation efforts, in my mind, pose some legal concerns as well. Maybe for individuals who don't want to take a test, either for religious reasons or other reasons. People who may feel that contact tracing that was just described is an invasion of their privacy, and I'm not going to tell you who I've been in contact with. So I'm wondering if you can talk about some of those tensions and how employers might steer around them.
Yeah. So when we counsel clients, tend to talk about 3 buckets of activities in terms of keeping their workers safe. So social distancing, and then face coverings and other infection control mechanisms, and then identification and monitoring. And with all of these, there can be some legal issues that arise, but thankfully, many of them have been answered by the agencies that are responsible. Now, that doesn't mean any of these are easy, and with all of these, it's really important to communicate to workers that the employer is doing this in order to keep the workers safe, and to communicate to the workers that everyone should feel a sense of collective responsibility in complying with these safety requirements. So you want to embed that sense of collective responsibility. So, and some of these things, the employer is going to have more control over than others. So employer is really going to have to depend on that sense of collective responsibility for some of these. So social distancing, that's things like maybe you'll have people do staggered shifts. So they're not having to go on public transportation when it's at the height of people being on transportation. It might be moving desks apart from each other. It might be saying no more than 4 people in a conference room. Okay, so just thinking about all the ways in which you have people congregating and now you're spreading them apart. It might be not having folks in a dining room, or so all of those things you want to think through. Second is face coverings and other, and then there's not any legal issues with that. Second, face coverings and other infection control mechanisms. So obviously, you heard from Dr. Andersen how important the face coverings are. You might well have employees that come and say, well, I think they're silly. I don't think they, do anything. And here, this is part of the training, right? We've used this training for anti-harassment training, where people say, I don't see what's wrong about telling someone that they look sexy. Right? And you say, fine, go tell your wife that she's sexy. But when you walk into the doors of this workplace, here are rules. And it's the same thing. You can believe whatever you want to believe about the utility of face coverings. But in this workplace, this is required. And it's required because we are respecting everyone. We have a sense of collective responsibility to everyone. And then if you have someone with a disability who actually cannot wear a mask because of some underlying medical reason, you should engage in an interactive process with them, see if there's some other type of face covering that will work, see if they're able to have an office by themselves, so they're only wearing the face covering as they're walking through some common area. But if not, if you really can't accommodate, it's a type of job you can't accommodate, then the only protection that person has under the law is to have a leave. It can be an unpaid leave, but it's job protected. It might also be that you should be thinking about if folks can telework. I mean, you should be thinking about that regardless if they have any legal right to telework, because it's a way of reducing the number of employees in your workplace. But in terms of people who have a legal right to that, it could be someone who can't wear a mask in the workplace, or someone with an underlying health condition as determined by the CDC that puts them at more serious risk of serious illness if they get COVID-19. The infection control, those are things like washing your hands, having the hand sanitizer, telling people not to touch other people's staplers and computers. But again, with all of these, you can't be everywhere all the time. So you really need a type of training that make people feel responsible. And then finally is the identification and monitoring. And so this now comes to testing. Absolutely taking someone's temperature, having them screen for symptoms at home. These are good ways of ensuring identification. These are ways that the CDC has said are good for identification, as does OSHA. So that's like baseline, what really every employer should be doing. Of the folks we counsel, some large employers are actually doing that at the workplace. Smaller ones, they just have people self-certified, basically at home. And then again, in terms of testing, you heard from Dr. Andersen, that is helpful. It's only a snapshot in the moment, but if you can even keep one person, 5 people who are infected, and you have found that at that moment out of the workplace, that's good. But it's still expensive. It's still expensive. And again, some large employers, especially employers where people have a type of work where you can't socially distant, they are doing testing. And again, here the EOC has said you can do the test, even though it's a medical test. That's the ADA has restrictions around that. Under the ADA, this is a job-related test that can be done because otherwise people pose a direct threat to others. But that CDC and OSHA has not mandated those testing. They just mandated that you identify and monitor. So it's sort of, that's a good way of identifying, but not necessarily a legal requirement. And the monitoring is making sure that if someone gets sick at the workplace, right? They felt fine in the morning, no symptoms, but at noon they're feeling the symptoms, making sure they know if that happens, they have to tell their supervisor and they have to leave the workplace immediately. And they then have to communicate to the employer whether and the employer says you must be tested for COVID-19, and if they're positive, to inform the employer, who can then pick up on, it's contact tracing, but not like the public health official. I mean, the lab that verified that that person was infected is responsible for informing the public health agency. An employer may choose to inform the public health agency, and usually in most states not required, but there's no violation of confidentiality to inform the public health agency. But it's sort of good, we're counseling good practice to ask the person, who have you been in contact with? And, hopefully having the person answer. Oh, one last thing you said in terms of people having religious objections or, the bottom line is that an employer has the right to have someone who's not a direct threat not in the workplace. And again, religious objections, there's a duty to, see if you can accommodate. But if it's an undue hardship, you don't have to accommodate. And that's both someone with a religious objection or someone who has a disability issue. And again, the best is, I'll end where I started, have your training of your employees, which many states and localities now require, not just be on the rules, right? Here are the rules that we're putting in place. Start with why you're doing those rules, which is to protect everyone. And you all have a sense of collective responsibility. And end that training with some skills building, right? That if someone isn't staying 6 feet away or isn't wearing a face mask, train people how to say, hey, stay in the safe zone is what we call it in the training we put together. How to in fact tell someone and not feel like they're snitching, or being obnoxious. You're not being obnoxious because you're protecting everyone.
So it seems like a lot of what you've talked about, though, really hinges on the cooperation of the employee, or training and hoping that they follow through. Do you have suggestions on how employers can really ensure this compliance beyond just the training?
Well, it's leadership, it's policies, it's accountability, and it's training. See, it's all 4. The training is not the only thing. It's not even the most essential thing, although it is important. It's the capstone, right? So leadership is making sure that your leadership knows how to communicate. The messaging here is so important, and that messaging has to come from the top. Second is having the policies and having the rules, right? You have to wear a face covering. No, there are only 4 people that go into the elevator. If you're the 5th person, you don't get to come in. Or if you're the 3rd person, right, whatever the rule is. So explaining the policies. 3, holding people accountable regardless of where they are in the business, right? It's someone who's high up and says, well, I'm in my office most of the time, so I'm not going to wear a face covering. Yeah, your rule is you don't have to wear a face covering if you're in your office with the door closed. But when you go down the hall, you have to wear a face covering, and that's regardless. In fact, if anything, again, when we help people do anti-harassment policies and accountability, it's the higher up you are, the more accountable you should be. And then, you've got power as an employer to send people home without pay if they're not complying with your rules. So that's the accountability. And then finally, the training is, again, the policies is to have the policy. The training is to let people know what that policy is. Very simple, clear English. And again, our mantra is here, the policy is not about changing people's minds. It's about changing their behavior. You're not in one training going to convince people whether washing their hands makes a difference or wearing a face covering makes a difference. So you're not trying to change their mind, but you're trying to change their behavior. And you have control as an employer if you hold people accountable to change behavior.
Thank you. I mentioned before that I wanted to reserve the discussion of antibody testing to stand on its own. I'd like to switch the focus to that particular modality now, mainly because there's been a lot of discussion about and media reports early on about the potential use of immunity passports, of testing people and separating them into people who are antibody positive versus people who are antibody negative, which, as a lawyer myself who worked in the AIDS crisis in the 1980s, is very chilling. The idea that there are two groups of people and you base policy reliant on the outcome of an antibody test. But that said, it is being discussed as in terms of its role, its potential role. So I'd like to talk about that for a few minutes. And Dr. Andersen, I think first I'd like to establish with you that what is the nature of an antibody test? There were a lot that were approved by FDA early on. They've walked some of those back, and there have been reports out of NIH that there are going to be new and improved antibody tests. Can you discuss for us both the effectiveness of antibody testing and then educate us regarding the clinical usefulness of antibody testing? What does it really tell us if we take an antibody test?
Yeah, so I think this is really important because this has been a little confused over time for sure. Now, all the testing we have talked about so far is to identify people with active infections, people that are infected with the virus, people that might actually get on the workplace and transmit the virus on the workplace. That's everything we have discussed so far. Antibody testing looks for prior exposure to the virus or prior infections with the virus. So you typically get people call these, binding antibodies. They can either be IgM, which comes up, fairly quickly, about 10 days after infection, IgGs, which typically take, 2 weeks or so after you're infected. But these antibodies then stay high. We don't know for how long you have these binding antibodies, but we know that after you've been infected, you're going to have antibodies to the virus. At least most people have antibodies to the virus. And this now becomes a way in which we can detect, have you been infected with the virus? Now, the earlier discussions were around, well, can we use this to say that if people that have had the virus before, can we assume that they are immune? And if they're immune to the virus, now they're safe to go back to the workplace. And this is the whole discussion around immunity passports. And there's several countries, Germany included, for example, that actually consider these as a way to divide people up. Now, what I will say is that there's several reasons why the idea of an immunity passport doesn't actually work. Forgetting about the legal and the ethical issues right now, which are obviously very tricky, but just strictly scientific. The first issue which we encountered early on, which is that, well, if you actually get an antibody test and you test positive, can you assume that that means that you have actually had the virus in the past? This is fully dependent on the accuracy, specifically the specificity of that test. really early on, and then, the level of exposure in the community. Really early on, all these tests were pretty terrible, specificities around 85, 90% or so. That might sound pretty good, but because our exposure in the community, most places is really, really low single digits. We're talking 2, 3, 4% or so most places, right? That if you got a positive retest on any one of these assays, it was much more likely to be a false positive than it was to be a true positive. So if you get 10 people testing on this, 7 of these will be told they have, antibodies, but they didn't actually have infections. That's false positives. The other 3 got a positive test and did actually have the infection. So again, this means that in most cases, you couldn't actually trust the results of the test itself. That I will say has been solved. Most tests that are available today are actually much better than that. They have much, much higher specificity. So I'll say this is less of an issue. But then that brings us on to the next issue, which is that, and there's 2 primary ones here. The first one is that we don't understand immunity. If you have binding antibodies to the virus, yes, you're more likely to be immune than somebody who does not have the antibodies, right? But we don't really understand yet, do you actually have immunity? And if you do, how long does it actually last? It's reasonable to assume that most of these people will have some level of immunity, but we have no idea how long it might last. If we're looking at the common cold coronaviruses, we're only talking a couple of months. If you're talking about some of the other coronaviruses like SARS and MERS, it might last longer, but we don't actually know. So this is an open question, and we will only solve with time, right? So we can follow these people. The last issue is what might you actually expect? If you say, I only want antibody positive people to go home, to go on the workplace. The issue is, again, that the level of exposure in the community is so low. So if you take any random office building, even if you take a hospital, again, you might only assume the low single digits of people actually having been infected and potentially positive. This changes in some areas, specifically prisons and meat packing plants, for example, where we see very large outbreaks. It might make sense there, okay? But everywhere else, it doesn't make any sense at all at this stage. Even when we're talking about the meat packing plants and the prisons, for example, we also have to remember that we don't yet know that if you have the antibodies, you are also immune, right? That remains to be resolved. But I would say that in those very, very special conditions, maybe there's some utility to this. Everything else, there's no utility currently.
Let me ask a follow-up to that. What are the implications of the possibility that an antibody does not confer immunity for vaccine development?
Yeah, so, and this is a good point, because it is, if you have your antibody test and you get the result of that, how do you change your behavior? When I started thinking about these, I think, well, people that have the antibodies, they might think they're immune, and then they might do things that is unsafe and actually end up getting infected and potentially transmitting at the workplace, right? This would be very true of people in healthcare, for example, doctors, nurses, frontline workers, right? So I was very concerned about that because, again, we don't actually understand whether you really are immune. But what I've come to realize is that, and we do this is here in San Diego, that when we test these people, very, very few people actually have antibodies. But most of us, many of us, myself included, I had a 6-pack of Corona bet on this. We thought we had coronavirus somewhere in January, February, March or something like that. I had this weird cough and I felt a little crappy for a couple of days, right? I was pretty convinced that that must have been the corona. It was definitely consistent with that. I'm young, maybe I didn't get that sick. I got the antibody test and lo and behold, it was negative. I lost my 6-pack Corona, which is fine, right? But what that made me realize, I didn't change any behavior because, again, I understand the issues here, right? But for a lot of people that we have tested that believe they had coronavirus infection in the past, we show them the result of the test, which is negative, which it is going to be for 98% of people, right? Is negative. It actually makes them change their behavior for the better because they had been behaving as if they were immune to the virus, and now all of a sudden they realize they're not. And I would say that right now, that is the biggest utility of, antibody testing. All these people that think they have been infected, only a very, very small proportion of whom have been infected, get the antibody test, show they're negative, saying, look, you should not behave as if you're actually immune to the virus. Be careful.
And is there a flip side to that, though, that if I take a test and I'm told that I have an antibody, that I might actually put myself in harm's way, assuming I am immune when in fact I may not be?
Yeah, so, and I think this comes back to Chai's, about communication, right? It's really important you communicate what does it actually mean. I should say that I'm a little less concerned about that because I think it's a reasonable assumption that for a good proportion of these people that do have antibodies, they have probably some level of immunity, right? Some level of immunity. What that really means, we don't know, right? But some level of immunity for a little while, I think it's a reasonable assumption. So I think it's okay that some of these people might do things that are a little bit more dangerous that really shouldn't be doing based on the communication about what does it actually mean to get a positive test, right? But importantly, it's also going to be a really small proportion of the population, right? Again, you test your whole office, you have 100 people, right? It might only be 2 people, right? In all likelihood. So I would say for those reasons, I'm a little less concerned about that. But with that said, though, it is really important to understand that having antibodies to the virus does not necessarily mean you're immune to it.
Ms. Feldblum, back to you. We've talked about antibody testing, and as I mentioned earlier, it was a very different situation in the 1980s when you could test someone for an HIV antibody and discriminate against them based on that because AIDS was recognized as a disability. You actually couldn't screen them out that way. Is the shoe on the other foot here, or what? Can I be a dentist and say I'm only going to bring in people who have antibodies into my practice?
Well, actually, in terms of the disability law, interestingly enough, if you decided to do that, that would mean that you were discriminating against people who had a record of a disability. You would not discriminating against someone who had a record of a disability, right? You're discriminating against those who never had a disability. And actually, unlike Title VII, which has reverse discrimination claims, right? You can bring a claim as a Black person if you would discriminate against being Black, a white person if you would discriminate against for being white. In the ADA, there's a provision that specifically says someone without a disability cannot bring a reverse discrimination claim. So actually, if you wanted to do that, you wouldn't have an ADA claim. But the question is, should you do it, right? I mean, again, with clients that I've been counseling, it's often the CEO that says, I want everyone to come back to work, even though that may not make sense. Or I want everyone to get tested. And what about this, antibody testing? And I know many of you are in communications. Some of you are in HR or legal. And it's what is it that you can bring forward in terms of information so that you are making an informed decision. So again, in terms of AIDS, HIV, remember, this was in the middle 80s. Right? The ADA, the anti-discrimination law, wasn't passed till 1990. And there wasn't a treatment for some serious amount of time. And the effort to get tested was, so let's test people and quarantine them, right? And these are people where they knew from the beginning HIV is not transmitted the way COVID-19 is. They're not a danger in the workplace. And yet there was that effort. So that the social meaning of testing changed. In fact, once there was treatment, and then, as Dr. Andersen said, usually you test in order to diagnose and treat, it was almost hard in the gay community to turn people around and get people tested. Here, this is different. This is spread through, the air in certain ways, through droplets, air potentially, but through droplets. So there is a reason to test, and there can be treatment. So there is, the fact that if you are able to test, that can make sense. For the antibody testing, it's different, and it's different legally and practically. It's different legally for the reason Dr. Andersen just said, in terms of what? So you're going to bring back 5 people when you need 500? Now, it might be if you're bringing people back in shifts, maybe you do want to, within that shift, have at least the 5 people that are more likely to be immune. The issue there is, though, under the ADA, you can't require them to take that test. You can't even, can't require them to take that test because you know what? That test doesn't tell you that they're not a direct threat, about direct threat. The whole point about the current, if you have COVID-19, then you're a direct threat. But if there's no reason, no job-related and consistent with business necessity reason, that's the piece in the law, you can't require the test. Can't even sort of voluntarily ask people to take the test unless you can potentially say it's part of a voluntary health program, but that's complicated. I would not do that without legal counseling. So legally, EOC, and that was just about 3 or so weeks ago that EOC came out and said no. Based on the new information about these antibody tests, it doesn't show if someone is currently infected, and you don't really know if they actually are immune for how long, so it's not job-related, consistent with business necessity.
Thanks. I'm going to take a check with you, Anne, and see, I know we have opened it up to see for people to hand in questions if they had any. I wanted to check and see if there are. If they're not, I've got some more.
We do have a couple of questions, and they kind of go into a couple different areas that are probably not necessarily medical or legal. They have a little bit more to do with in judgments of employers, so they should be interesting for this group. The first one is coming to somebody on the line that says, we understand the importance of masks. We have a warehouse operation that is not air conditioned. We have large fans that circulate in the air, but in the summer it gets hot. What's the recommendation on use cases like that, where you're actually, there's a discomfort around the safety measures?
Yeah, I'll say to go back to the science a little bit, right, is that is recirculated air. And we have now seen multiple examples from multiple different countries where recirculation of air can lead to large-scale infections, right? So we have examples from restaurants, we have examples from call centers, we have examples from restaurants and other places, right? So there's a lot of examples where clearly this is actually airborne transmission. Now, airborne transmission is controversial, but I would say the data is clear to me. So in a situation like this, yes, it gets hot, but because you have recirculation via fans, and if you have a lot of people together, it is even more critical that people wear face masks under those circumstances, not less. I understand it's super uncomfortable, right? But it is unfortunately what is necessary. This is especially true if people are talking, if they're shouting to reach other people to tell them things. This becomes even more important. So I would say even though that this is super uncomfortable, it just has to be done.
And what I would say in terms of sort of the OSHA requirements of making workplaces safe, this is a moment in time where employers need to, what I call, stop, think, and justify, right? So you've always had it this way. You haven't had air conditioning. You've just done it with the fans. You haven't had windows open or, changing the layout. And especially with the economic stress, so many of these companies do not have a lot of extra money, and I'm very sympathetic to that. But at the very least, you want to think, is there something I can do with this physical space that I didn't think about doing before, but maybe I can do now? Let me bring in an expert who can see, can we somehow have this not be recirculated air? Is there something we can do? Probably too expensive to air condition folks, but, perhaps something. Maybe it's a type of job where you let people take breaks every 3 hours. Well, maybe you'll let people take a break every hour. Again, obviously that affects productivity. Yes, but do you want that or do you want an outbreak? Which is going to mean you're shutting down the whole workplace and potentially for a full 2 weeks because you want everyone to go home and quarantine. So stop, think, justify the decision you make.
Thank you. We've got another question. This one is about parents and schooling. So with the potential that schools will not be operating as normal in the fall and companies requiring their employees to go back to work, what should companies be thinking about and doing with regard to this situation where there may not be childcare, but there's also kind of these obligations of employers as well as employees to get back to productivity?
Yeah. So this is where you have a set of different laws, and this is where I think you're going to be lucky if you have fewer than 500 employees, and not so lucky if you have more, just in terms of the cost, right? Because if you have fewer than 500 employees, the federal government will pay for essentially 12 weeks for that person to stay home. I mean, again, that's not the whole time that school is in session, but it is 12 weeks. And it doesn't come out of your money at all. If you have more than 500 employees, the federal government isn't going to pay for it. And those folks don't have a legal right to stay at home and get paid leave. If they have to quit for that reason, then they can get unemployment compensation. So, and that can go for, as I say, for 39 weeks. That ends December 31, that extra unemployment program. So, you know, I mean, I think for employers, there is an issue with productivity. I mean, there is an issue with potentially losing employees. Like I said, so 12 weeks, you don't have to pay if you're under 500 employees, but then you don't have that employee for that amount of time. And certainly if they quit and get unemployment compensation, you don't have them. So, you know, there's not a good answer to that. And that's because we're in a pandemic. We're in a pandemic. And given that, some schools may not open. And it's about, you know, maybe this will start having more, really more gender equity so that, you know, if it's in a heterosexual couple, the woman stays home, you know, for a period of time if she's able to, and then the husband stays home or the partner. It's not easy. You should know the laws that exist. You should know the paid sick laws and the unemployment compensation, because that'll help you advise your employees.
Great. We've got another one about, it was a follow-up to the discussion about masks, and it was asking what the role of face shields are as an alternative to masks and kind of the merits of one versus the other. Dr. Andersen, you want to take that on?
Yeah, I think so. This is definitely tricky, right? If we're talking about droplet transmission, somebody might sneeze on you, or somebody might be close to you. A face shield might actually help, right? Because it will prevent those droplets from getting in your face and sort of touch you that way. The problem is that if we're talking about some of these recirculated air type of situations, probably won't be sufficient, right? Because that is actually the virus floating around in the air. And again, there are multiple examples from office settings and others of this types of circulation, right? So I will say that they have some utility. They won't totally prevent, but neither will face masks, right? They have some utility. I will say my preference, if I had to choose between one over the other, would be face masks and not actually face shields. I also think the really important thing to remember here is that face shields are probably more to protect you against air droplet transmission versus face mask, which is much more about protecting the community around you, right? It's when you're sneezing, it's when you're talking, you actually, the face mask help prevent you spreading droplets, spreading aerosolized viruses, right? So I think it sort of depends. Again, they're not completely useless, right? But face mask is probably the better option of those two for sure. And again, face shields will do very little to protect the community right around you. It might, if you sneeze into your face shield, it'll probably just splatter there and stop there. But chances are that that won't actually help a lot in terms of protecting people around you.
Great.
I wanted a different answer. But that's an important answer. I mean, I find it very difficult to wear a face mask, and I feel blessed that I have a job where I can completely telecommute and make my full salary. And there really is an adverse impact here based on race. I mean, Black and brown employees much more likely to have jobs where they have to go in. You know, so that's really hard. And especially I was hoping maybe for a person with a disability, that could be an accommodation, but maybe that can be part of an accommodation, you know. But I do think employers need to know that information that you just gave, Dr. Andersen.
Yeah, I mean, I think, again, the issue here is, right, that going back to my first comment, which is that I am convinced that certain states in the United States right now are moving towards a catastrophic situation, right? I wish that I had better answers. I wish that we could do better accommodations. I wish all these things. But because we as a country have totally failed to get this under control, and by totally failed, I mean totally failed, right? There are unfortunately things which is going to be necessary in the United States, which is not necessary in many other places. Denmark, for example, where I'm from, schools are open, nobody's wearing face masks, right? And it's fine. Cases are continuing to go down. The problem is we just can't do it here. We also can't go to bars. We can't eat inside restaurants. We can't go to sporting events. We can't go to the cinema. We can't all do all of these things, which is hugely inconvenient, but it's the reality that we're in right now, unfortunately.
I want to thank you both for your wise words today, and thank everybody for watching us. We weren't here to give legal or medical advice. We were here to show how complicated this is and how necessary it is to have the facts so we can communicate.
Thank you both.
Everybody.
Thank you both as well. And we look forward to continuing these topics because, like Mark's saying, there aren't answers right now to a lot of it. But if we piece together all this really valuable information, at least we have a path to follow. So thank you.
Thanks, everybody.
Thank you.
Goodbye.
Bye.
Bye-bye.